welcome to the program Healthy Living on Trust Television. I'm Aisha Salihu. Today on the program, we'll beam our searchlight on the development of health insurance at subnational levels. You'll recall that the National Health Insurance Authority Act, established in 2021 to implement the national health insurance policies to attain universal health coverage, is in effect. About 16 million people is below 10% of the population covered in 2022, according to the Director General and Chief Executive Officer of the National Health Insurance Authority, Professor Mohammed Nasser Sambo. In an earlier interview, Professor Mohammed Nasser Sambo stated that restructuring measures were initiated to expand the fiscal space of health insurance coverage, awareness creation of health insurance, digitization in terms of service provision, finance, among others. In line with this development, our main take is on the ripple effect in states across the Federation. I have joining me virtually Dr. Jafar Ogi Mohammed, who is the Executive Secretary and Chief Executive Officer, KB Contributory Healthcare Management Agency, to explore some perspectives. Welcome to the program, Doctor.
Good afternoon. Thank you for having me.
Now, the NHIA boss has spoken tough about the changes, in the NHIA following its establishment and changeover from NHIS. What's your take on this so far within the state?
Well, I think it is really a very good development with the passage of the NHIA bill into NHIA Act 2022. A lot of innovations have been brought about in the health insurance ecosystem in Nigeria. First of all, for the first time, we have a law, an act that speaks about the state social health insurance schemes and agencies in Section 13 of the NHIA Act 2022. The presence and legality of the state social health insurance agencies that they provided for. Equally important is the introduction of the BGF, the Vulnerable Groups Funds, in Section 25 of the NHI Act. The mandatory nature of the social health insurance scheme in Nigeria, as contained in Section 14 of the NHI Act, is equally very important. So I think, of course, there are still some lacunae that the stakeholders in the ecosystem have to sit down and work out. We, at the subnational level, we are very aware of the kind of innovations and futuristic thinking of the DG of the NHI, Professor Mohammed Nasser Sambo. He's trying able to introduce the health insurance under one roof, which will bring the states as partners in trying to see that UHC has become a great country in Nigeria. And we are working together with the national to see that we achieve that in our respective states. So really, I think it is a very good development that we have the NHI Act. All the 36 states in Nigeria and Abuja have their own legal frameworks, their own respective laws passed by their houses of assembly, and Akebi is not excluded. Well, we have the Kichema Law number 2 of 2018, Akebi State Contributory Healthcare Management Agency Law, which was passed in 2018 and assented to by the then executive governor of the state into law on the 31st of July 2018. So since then, we have been trying to see that we implement not only the state scheme, but also the Basic Healthcare Provision Fund, which is, as you know, is a national program provided for by Section 11 of the National Health Act. So I think we are coming up, and I'm sure all stakeholders now recognize the importance of centralizing the social health insurance schemes or scheme in Nigeria. And I think it's a very good development, and it's the best way and the right way to go.
In line with innovation, I know there is consolidation of programs for employees of the formal sector, employees of the federal sector, and also the informal sector. And now you did talk about the provision of implementation of the Basic Healthcare Provision Fund, which is to cater for healthcare delivery system where there is access to 1% of consolidated revenue. That's about 50%, which goes to NHIA to be distributed to the state through the health insurance agencies, to cover the vulnerable population. How would you say this has been in place, especially KB, for example?
First of all, we need to understand that the Basic Healthcare Provision Fund should be looked at as a source of revenue for covering more lives in our journey to achieve universal health coverage. It's not supposed to be a project or a program on its own. I think, to me, it's an assistance from the federal government to enable the states to cover more vulnerable individuals and groups in their respective states. The states have to understand it in this context by releasing equity funds that has been captured in the respective laws of the state, so that more lives, vulnerable individuals are captured and covered under the social health insurance scheme in their respective states. One of the major problems the state schemes have is for our policymakers to understand that they have to come in and not just leave everything to the federal government. Even the 25% counterpart funding for the Basic Healthcare Provision Fund, unfortunately, have not been coming forth from most of the states, not all, most of the states. And the counterpart funding for the formal sector implementation, for instance, very few states are given the employer contribution as stipulated in their respective laws. I think those are misunderstandings that the stakeholders at the state level must understand and act accordingly, play their role wisely and release equity funds, release counterpart funding for both the Basic Healthcare Provision Fund and the formal sector employer contributions, so that we'll have more lives covered in the respective states, and consequently, the number of lives covered in Nigeria under the social health insurance scheme will increase. We appreciate. It is important to understand that, well, let me talk personally here, that what I understand is that no matter who is covering lives in Nigeria under the state social health insurance scheme, we are working towards one objective, the objective of covering each and every Nigerian. Our schemes are mandatory. It is mandatory under the NHIA Act in Section 14. It is mandatory, for instance, under the Kebbi State Contributory Management Healthcare Management Agency Law in Section 10. So it is just a civic duty for all residents in Nigeria to be registered under one form of health insurance or the other. What we need is to cover all by 2030, if possible. That is the goal. And to me, it doesn't matter who is covering what portion of the residents of Nigeria. What we need is to see everybody.
Let me cut you.
So in Kebbi, for instance, we celebrate the success of the NHIA when they get people being enrolled in the GIFSHIP.
Some of these funds are expected to come into the healthcare system within the communities in the states and not properly accessed, and they are not judiciously used the way they ought to be used. How does the NHIA, accounts for its judicious use and proper implementation of this basic healthcare provision fund, just so it reaches the vulnerable population? I mean, women within the reproductive age, children under 5, and also people with disabilities and people in disadvantageous positions.
Well, it depends on the states, really. In Kebbi, I can speak of Kebbi. And in Kebbi, we use the National Social Register or the State Social Register to target our beneficiaries. However, the register has some problems, which we try to address with the State Office of Fiscal. And in different states, they have different challenges with the register. But in Kebbi, I think by and large, register is workable, and we are using it this year for the first time to enroll 100% of our enrollees. Before now, we used to use both the register and also other targeting mechanisms. For instance, we used to target eligible beneficiaries through the traditional institutions, through the groups of vulnerable part of the society, such as the physically challenged, the orphans from the Ministry of Women Affairs in the state, and so on and so forth. We used to do that. Why? Because the register was not covering all the 21 states we have in Kenya. But this year, the register has covered all the 21 local governments. Therefore, we used to go to the field with our register, and when we have problems, for instance, change of name or transfer, or when we cannot identify the individual where he has been registered to be a resident, we use other mechanisms to fill in the gap, because we have 225 political wards in Kenya, and all these wards, they have right to have their beneficiaries captured within the basic health provision program. Okay. And we one of the major issues is equity. Trying to see that not a single political ward is left behind. Of course, we are choosy in terms of the PHCs and the general hospitals that are participating, because we didn't take all the 225 ward facilities from the first year. We started gradually, and we are expanding. And today we have 122 PHCs, 29 general hospitals.
Family Social Health Insurance Program, the GIFSHIP, intended to bring the informal sector of the population, that is, we're talking about the self-employed people working in organization with less than 5 workers, also expected to take responsibility of 83 million poor people, poor Nigerians with no financial access to healthcare system. How would you say the aim and objective of this GIFSHIP has been achieved so far since its creation, especially at the subnational level?
Well, I know that the National Health Insurance Authority do quite a lot in this respect, because I happen to be a member of the Innovative Financing Committee that the DG has created to look into the possibility of finding ways to cover 83 million Nigerians that we are targeting. Unfortunately, the rate of poverty is even increasing. I'm not sure if we still have only 83,000 as our target. I think it's somewhere over 100 million now. However, I think our subcommittee has submitted to the DG a lot of innovative ways that those amounts can be raised. I think Nigerians should not make any mistake. Health care is never free. Somebody must pay for it. So the notion that the federal government will bring money to cover for all, I think is a wrong one. We have ways that God willing, if used efficiently, we can cover most of these millions we are talking about. I think we should also pay attention to the informal sector. The individuals themselves, those that can pay must be encouraged to pay. And this is talking about implementing the mandatory nature of social health insurance in Nigeria as it is by law now. People that can pay must be encouraged. Let me say that, must be encouraged to pay because it is a civic duty. Only those vulnerables that we know cannot afford, we should be looking at ways that the government and other informal sector players should come in and cover for them. But those that can pay, trade-based associations, faith-based associations, and community-based associations, they should come forward as a group, as groups and pay for the informal sector. They must not wait for the federal government or state governments to come and pay for them. Only those that are really vulnerable eligible such assistance should be targeted.
I interface with some Nigerians who have issues with the fact that the provisions in the National Health Insurance Act does not necessarily cover many of their healthcare challenges. Let's take, for example, surgeries, operations, or say maybe family planning methods, or also for people who are looking to have maybe a reproductive assistance through the use of technology. That's people with fertility challenges. I've had some of these cases come up where they say the health insurance does not cover for some of these major healthcare challenges. How then do you think the NHIE can bridge that, just so that some of these challenges, these major healthcare concerns, are covered within the programs created by the NHIE?
I think we must understand the principles of universal health coverage. It all depends, the population you can cover and the sciences you can cover depends on the revenue you can pool and the and where and how you are going to purchase those services. It is very important that we understand that it is our pool that will determine whether one service or the other is included in the benefit package. We say first things first. Nigeria, we are bedeviled by maternal mortality and child mortality and malnutrition. malnutrition, to be specific, we found here in Kebbi that is a problem, especially in the grassroots. And that is why in Kebbi we are looking forward to including the RUTF in the benefit package. It may not be so with some other states, but it is a relevant issue here in Kebbi, and therefore we have to include it. To answer your question, it all depends on the pool we have. Is that pool strong enough to cover for more services as we are covering for more population? That is important. And how do we strategically purchase these services, from whom and how and where is equally important. Where is important because in Kenya, for instance, the cost of medical services are cheaper than elsewhere. I'm telling you, cheaper even than nearby Sokoto State. So you may not compare the cost of services in Kebbi with the cost of services, for instance, in Abuja. It all depends. It all depends. And while artificial insemination, for instance, can be a big deal for people in the urban areas, it may not be for people in the rural areas. And it's not about UHC, it's not about serving only those living in the urban areas. And that is why when we are making our calculations, we put the people at the grassroots who are by far more, probably up to 70% of our population. We put them in the scope of things. So to answer your question, it is about the pool we have, whether it can sustain those services or not. And remember, the UHC is about having the basics first. The basic minimum package of healthcare services is what we are offering. In Kebbi, in fact, we use the benefit package of the basic healthcare provision from as a starter. That's what we are using now. Okay. I think in other places, big places where they have big hospitals and participation of the private sector more accurate, they may have even more services covered under their respective schemes. I don't know, it could be on the private schemes or any other arrangements
that have been created by the NHIE and how they have been implemented so far, and who and what they are expected to tender to. Now, I'd like to know, take for instance KB as a case study, because you're speaking from KB State. Let's look at some of the challenges and also the successes achieved in KB healthcare system, just very briefly.
Okay. Well, the successes, we have covered over 122,000 vulnerable individuals and groups in Kenya under the Basic Healthcare Protection Fund. We started our formal sector just recently, about 3 months ago, and we have over 11,000 civil servants registered already, and the process is ongoing. As for the informal sector, we have 10,797 lives under the informal sector of our scheme, and the population is growing. I think that can be attributed to the participation of the formal sector. Formal sector have long been wishing, showing their interest to join, but they were not given the avenue to join so recently, and they are coming now. Is bringing a lot of positives. First of all, people have seen that, well, it's not only the villagers and those that are not under the civil service that are being invited to join, even the educated part of the society, the civil servants are joining the scheme.
At this time. Thank you so much for joining us on the program, Dr. Jafar Ogi Mohammed, who is the Executive Secretary and Chief Executive Officer, KB Contributory Healthcare Management Agency. Now remember, health insurance is mandatory irrespective of location, social class, employment status, age, and religious affiliations, and do well to demand for the implementation of these programs by the NHIE in an event they are not being implemented in your state. With that, we've come to the end of this episode of the program. For comments, contributions, and suggestions, do well to subscribe, like, follow all of our social media platforms. Join us again on another episode of the program, Healthy Living on Trust Television. I'm Aisha Salihu. Thanks for your time.